significant outcomes in a very small time scale. So our measuring stick for NeuroPhysics therapy is a 4-day period of time. So we expect to see some significant measurable changes take place within these patients, where we've seen return of lost functions in lots of cases. So the relaxation of symptoms, and in particular spinal cord injury, where we've been able to produce some very profound outcomes for people that have been very well publicized globally through the media and so forth, because of the significance of those returns of functions. So this presentation, during those presentations, I always delved into some of the methods and the techniques that were used for NeuroPhysics therapy. But this time we're going to delve a little bit deeper into those. So very much this presentation is more about the techniques and the philosophical approaches to NeuroPhysics therapy, and helping to explain why we're able to accomplish those results in such short periods of time. So I'll just get onto the full screen here. I'm just making sure that I turn my video on, because there is some talking within those videos that that the audio will come on. I'm pretty sure that should be okay, but if somebody can let me know whether the audio is working when we get to that stage, that would be wonderful. Thank you. So for those who are not aware, the question is, what is NeuroPhysics therapy? Well, neurophysics per se is a branch of medical physics in science, and they with the study basically of perception, action, and cognition, using very sensitive, discrete physical techniques to do so. So usually functional MRIs and PET scans and the likes are able to do that. So to study these online things, and to integrating tools from neural networks and complexity science to analyze data, and to build theoretical frameworks around the nervous system's functionality. I founded NeuroPhysics therapy more than in the late 80s, and I'm proud to say that since then, NeuroPhysics therapy has earned its own footprint within this branch of science. I too did develop tools to be able to assess and make online assessments of a person's perception, action, and cognition as they're going through the therapy. But for me, it's been a reverse engineering process, where back in the late 80s, when I was starting to develop my program, and I was set out from the beginning to develop a program that was able to treat 100% of the people 100% of the time. The caveat being that people must want to engage and they must want to get well. So we can only help people who really want to do that. We can't help people who just feel they're going to get plugged into a machine, or some other intervention is going to take place where these people really are prepared to do the work, and lots of times be confronted with themselves in that process. So that's first came all the outcomes. So I was achieving the outcomes based around the program that I developed, which took a few years, and was based around lots of observations of many, hundreds and hundreds of people over that period of time, to come up with a formula, we come up with a program that was effective, that we could effectively measure outcomes and effectively measure perception and cognition along the way. So since then, we've become very successful in what we've been doing. So there's been a lot of international and national media attention attributed towards the outcomes of people who've gone through NeuroPhysics therapy. So the BBC and 60 Minutes and likes, and this all culminating in Academy Award nominee Stephen Pazlowski's beautiful film called Calibrate, which is about people who've come from all over the world for their therapy, telling their stories and how they were treated through the medical system and so forth, and the outcomes. So it's a beautiful film, and hopefully one day you might get a chance to watch that. So these are some of the, the disorders that we've been able to treat over the years. So there's quite a few, and of course, as everybody who's here is aware, that there's been many conditions that have been coming on. There's many rare diseases that we're being confronted with in the modern, bigger, stronger, faster world that we live in today. All these, what we see here, is extracted from the Frontiers, the hypothesis, the NeuroPhysics therapy hypothesis that was published in the Frontiers of Clinical Physiology back in 2013. And since then, that publication has become extremely popular, and it still is, where it's boasting more than 92% more views than any other publication in all of the Frontiers journals, and more than 85% more downloads. So it brings on board a lot of sciences, so in particular neuroscience and chaos theory and complexity science. So there's a lot of network science in there as well, to try to explain why this is the case, that we can get these outcomes in such short periods of time. So of course I had to look at through a different lens, and through the lens of complexity, I wasn't able to sort of, when I had to develop some type of scientific value for the work that I was doing. There wasn't a lot in I was well versed with neuroscience and neurology. There wasn't a lot in there that would help explain the sudden transitions where people who've been in long-term complex states, very advanced stages of certain things, could experience returns of functions. Not all functions, of course, but significant returns of functions in very small timescales. The plasticity modeling at the time wasn't that helpful because it required a repeated stimulus over time to produce these outcomes. But as I said, these were taking place within very small timescales, and even particularly on the very first day that people engaged with neurophysics therapy. As I mentioned, I was doing this a long time back, and during the mid-90s to 2002, I operated out of a private hospital. So the machines that we see in use there, which is what we'll be discussing later on, which provide the grids and the stable backdrop to be able to measure changes of behaviour, measure initial conditions of a person's system and changes of behaviour accordingly. There was a mental unit in the hospital as well. So on some stage there, the psychiatrist wondered if it would be helpful to some of his patients. Again, the caveat being that people would have needed to get well, and we found that very much going through the process the way we did, that it was helping to normalise people's mental states. We've used a lot of different techniques over the years to gather data, some sensitive data, so pre, during, and post neurophysics therapy. So one of the methods that I originally used was simultaneously EEG, ECG, and EMG data. So the EMG data were extracted from the trapeze muscles, the abdominal muscles either side of the abdominals, and the adductor process on the inner thigh. So they're all sensitive regions of the system, can very quickly tell us how a person is emotionally poised within their environment. So as we see on the screen there, the EEG was put on pre and post premotor and motor cortex, and the ECG is the ECG, of course. So that gave us a very good systems-wide view of what's actually going on in the system. It's something that I highly recommend to do rather than just taking EMG samples or ECG samples, because the autonomic nervous system is involved in all of this, of course. So we'd see the pre, we'd take some data during neurophysics therapy, and then we do the post neurophysics therapy. So we only had to ask some very simple questions with that. Did the intervention help the system to increase in complexity? Because it's viewed that disease, disorder, despair is seen as a loss of the system's complexity. So that's all that we needed to ask. And by sending my data away to get objectively analysed, that we come back and we could safely say, yes, there's been an increase in complexity in the system. But that was all post the fact that the people themselves actually reported, and we could see measurable functional returns and so on. So all we needed then was the data to help to validate those changes that took place. We've used technology like the Zebras technology, the gait and the stance analysis, because we can also get some pre-gait and stance analysis for the person on day one before they do neurophysics therapy, and then on day 4, post-neurophysics therapy, so we can see the changes that occurred. So they're not practicing that in the meantime. So we can see there's been alterations to gait, which means there's alterations to the person's relationship they're having with their environment, and it all comes back to a relationship that we have with the environment will determine our perception of our environment, will always determine how we physically and emotionally navigate our environment. So as I said, there's some data there. We see the people connected to all the electrophysical machines, but what was very, very good to see as well was the thermal imaging. So this is taking a very, very high pixels. So we see the initial condition of a person sitting here, and the heat is where all the white, that's the hottest areas. And that's typically of the trapeze area, which is very interconnected to the sympathetic nervous system. And that's what we see typically of most people who come with pathologies, that there's been long-term activation of the sympathetic nervous system. That was only meant to be activated if a lion jumped out of the bush occasionally, but in today's bigger, stronger, faster world, people are like that 24/7. So the parasympathetic nervous system isn't able to do its job of normalizing the system. So that's what we refer to as allostatic overload. So hence the reason why we take the EMG from the trapeze area. But what's very nice to see is as the person's going through the process, like heat is just energy, of course. So in a healthy system, we'd like to see a nice uniform distribution of heat and energy through the system. And what we'd see in all cases was that as these people started to go through the therapy, and they'd open up and allow their system to process environmental information against a stable backdrop, being the machines that they're using, which provide that backdrop to measure, that their systems will naturally start to induce this greater sense of flow and distribution. So if a person, for something simple, let's just say they had a frozen shoulder, you would very much see that in the thermal imaging to begin with. And then as you see, as time goes on through the process, there's a liberation of that heat and energy through there. And it's just a shame that thermal imaging isn't recognised a lot for its value in the medical sciences. So we need to discuss the role of the association cortex and sensory integration of perception and perception. As we're all aware, we don't experience our world as a separate sight, sound, touch, or smell. It's a flow of information for us. And all we're basically doing is tapping into one of those pathways, basically the somatosensory pathway. So the integration of the somatosensory with the visual system is obvious to help us to navigate our environment, but it's the visual system that also helps to maintain rogue patterns of behavior. So it's how we experience our world through our visual system will very much dictate all of our skills, the good, the bad, the different. So for an elite tennis player, their visual system is so highly evolved that even on any particular day, they can throw the ball up in the air and it doesn't really matter what the wind's doing. They're not looking at that ball. And they do their tennis serve. And as you'll see in slow motion, when they're doing that serve, that their hands will make an online correction to correct the ball to where it needs to go. But of course, if a person's suffering from a depression and they're walking around with that, you're not going to see that person walking through a shopping center, chest out, shoulders back. For example, they'll maintain a certain postural state and that which maintains the metabolic conditions that are very much interconnected with the feeling of the depression. So in the visual system really plays a major role because it doesn't play a bias about what is good or what is bad. It's just doing its thing of maintaining our skill set. So they it helps to maintain the skill of the depression. So however, we need to, when people are going through the process, we're working the machines, they need to close their eyes so the focus can then turn to much more somatosensory information and basically as well as how they're emotionally perceiving that information taking place. So the rules are that they're in a safe, supported environment. There's no lions running around the room. They have all the control. All they're being asked to do is engage with the particular machines. As I said, I'll explain more about that later, and move those machines, the arms of them or the legs of the machine through the fixed plane trajectory. So there's like this very stable backdrop. And then when they're doing that, that's when we see all these sensory perceptual errors start to occur. So as they're moving across those planes, we'll see underlying fears and anxieties will begin to emerge that aren't a reflection of the true aspects of the environment at all. So that means that they're all to do with associated experiences, past experiences that the system is referring to. It doesn't start inventing responses because they're sitting on that machine. It relates to its history to do it. So like I said, associative memories and so forth becoming triggered. Sometimes people might get vivid recollections of events that have taken place in the past. Other times, emotion will spontaneously emerge. So we have to go through that bit at a time and calibrate that. So as they're going through those planes, if they start to feel that unjustified anxieties emerge, we need to stop it there, calm things down, where the person's got to keep thinking about flow and distribution. I was talking about with the thermal imaging, flow and distribution. So the movement, whether they're using their arms or legs to do the movement, it's not an arm thing or a leg thing. It's a whole body experience that they're trying to engage in. And in particular, picturing themselves inside a grid to measure it for. So by systematically going through and detraining all those rogue responses, you've altered the initial state of the system, and the system being sensitive dependent upon initial conditions, which is what we've seen when we first went through in the first repetition or first attempt they had. That's the initial condition. That's interconnected to everything that's going on in their system because it's scale free. So all the good, the bad, the indifferent. If we need to alter that, then we need to alter the initial conditions that are giving rise to that. And all I said, it goes back to perception. How we perceive our world is how we're going to respond to our world. So just a brief overview. So I said it's a form of therapy that by design can begin to quantifiably enhance psychophysical deficits in very small time scales. So I said we have this 4-day measuring stick where we can see what people start with on day 1 to how they end up on day 4. And the expectation is that we see some significant alterations to behavior and functional returns and so forth. So the people that I'm showing here on the bottom of the screen, they're all stroke survivors. And this just helps to demonstrate the true value of having a reliable, stable grid. And I'm saying a lot of these things because when other therapists and or researchers that need to feel that they've got to have some type of stable grid to get reliable measurements from. So with the unilateral machines as such, we've got to think about it. It's not about exercise. It's just simple information processing. So we're just taking, all the person is doing is having an environmental experience, a sensory environmental experience. And we're looking at how they're responding to that. So the handle, that's just a way of getting information up to the brain. So then they can assimilate that information and to form those responses. So first we sense and then we respond. So with the stroke, of course, there's been a lesion to one hemisphere or the other. So that whatever the side lesion would be, the opposite side of the body is affected, as we know. So by going through the grids very systematically and using we have to help, of course, with the person to move their arm through that fixed plane of the machine.
Ken Ware, sorry to interrupt you. Your presentation is not on screen. Could you please reshare it?
Oh, okay.
It just got disconnected.
Your screen is sharing. Okay, so well, it's telling me I'm still sharing, so I can stop share. Share. That's a shame. Is that on there now?
Yes, please put it on the screen mode. Thank you.
Okay, so is that okay now?
Yes.
Okay, great, thank you. So I don't know how much we missed there, but the machines that the people are working on, like I said, they're stroke survivors. Now, as we're going through those fixed planes of the machines there, we have to obviously help to begin with, but we can give the person feedback. So it's very important that both hands are moving through the same plane in space-time at the same time. So the hemispheres of the brain are having the same experience. So in that condition then, the left hemisphere, if the left hemisphere had the lesion there, it can learn from the right hemisphere about what it needs to do to normalize that movement. So obviously it's got to construct other pathways because of the lesion to be able to do that. Now we'll use that arm and we'll give it a tweak so the person gets some feedback as to where their hand is relative to the other hand. And they're trying to become very relaxed, of course, but normally we have to detrain some of the effort they're putting in from the opposite hand because it's just trying to do everything. So we've got to tell them to relax the arm that has been functional to allow the other arm to do more work. And that little simple technique is very, very important because the hemisphere is just going to keep trying to dominate that effort. So going through there a little bit at a time, and the first day we go through, people start to generate some ability to respond to those movements. So by the time they've gone through a few days, they can start to get almost full range movements going through that. And again, it's still thinking all the same rules, getting a sense of flow and distribution. So not trying to make the lesion famous at all, just seeing that the system, given the right sets of conditions, will want to increase in complexity. And one hemisphere wants to mirror the other hemisphere. So we've seen some amazing results come from that. So just a bit of reflecting on history a little bit and where things really started to get going for neurophysics therapy. It was John McClain. He was a very well-known Olympic paraplegic, athlete paraplegic. He was the first person to complete Kona, the Hawaiian Ironman, as well as swim the English Channel as a paraplegic. So John was very well known around the world, and he came to me in 2013 for some pain management. I'd never worked with a person with a spinal cord injury before, so this was a completely new experience. There were people with spinal cord injuries would come to my centre with the physiotherapist, and the therapist would take them through and do work in my centre. I'd perhaps give a bit of advice about some exercises, but I've never had hands-on experience with a person with a spinal cord injury. So we can look at this and say there's complete innocence there. However, when I started to take John through the process, and we're going to the discussion about the grids now, I'll just leave this. These are videos, but I just need to discuss a bit about it first. The other thing that I have been exploring is the underlying natural chaotic rhythms of the nervous system. So the resting state of the brain is chaotic, and it needs to be that way so that we can transition through different states very smoothly and seamlessly. It's when the brain becomes less chaotic, that's when pathologies emerge like seizures. So we have apparatus, we don't experience that chaos at all, of course, because I can pick up my cup of coffee and drink my coffee without spilling it all over the top of myself. But when a person learns to transcend that experience and just learn to really relax under these mild conditions, the system will a mild tremor will begin to emerge, which is the chaotic rhythms of the nervous system. The more they relax, the more will increase in value. So it gives us a very good picture of where the system's at, how it's processing that information. So anything that's happening beneath the neck, of course, is all to do with brain dynamics. So John, he liked to film everything. So very grateful for the fact that these moments were filmed. So we had all these very valuable footage to speak to. Now, so I'll just show you this footage now. This is the value of the grids. Without these grids there, this dynamic would never have been possible. So it's back clicked on again. So as John learned to relax there, and he's thinking about flow through his body, so still thinking about flow as if that was flowing through his body like water flowing through. As that started to increase in velocity, you see what took place within his legs. Now, John had no capacity whatsoever to voluntarily control his legs like that. So that was just that information coming through there. Now, obviously, we can't create neural pathways that fast. They already have to be there. So this gets back to belief systems about. So I said to John at that time when that started to happen, and that increased quite significantly in velocity. And because of my innocence, basically, I said, John, everything seems to be working. I can't see why you're not able to walk. So I was just calling it as I seen it, because that was a typical normal response, the abduction and adduction, and very much in sync with what his upper body was doing. John did get a bit offended with that, because he assured me that he'd been around some pretty smart people in his day, and they assured him that he was never going to walk again. And I apologized and said, okay, well, that's okay. We'll just get back on track and we'll just focus on the pain thing. We'll just ignore those dynamics. But, I realized obviously the central pattern generators are working fine. And now those those dynamics increased in such high velocity that it actually blew one of the cables off the pulley there. And I had to put John on the adjacent machine. There you see the red machine on the back there. And this is what progressed over time. So quite significantly high velocity going through there. I'm sure everybody understands that these dynamics aren't possible unless it's all to do those connections are going through. In particular now, just watch what happens when John disengages. His legs flop straight back out the side again. So he's looking quite bewildered there, putting it there wondering what the heck was going on. We got into further discussion and I said, look, everything seems to be there. It's all ready. However that's happened, I'm not sure of that. So as we went through the process, he had to have tremendous faith in me when I'm placing his feet up on leg machines. He would open up his system the same way, and then he progressively learned to tap into those dynamics and actually increase the velocity voluntarily. And this is a quite incredible footage, because this is John. 3 days later, he took his first unassisted steps in 25 years. And just the fact that you can see him standing there stable, that was a lot of work going through many of the grids, all the upper body ones and the lower body grids, going through very slowly, very discreetly, a little bit at a time, stabilizing himself at every point in space-time as we went through, maintaining that sense of flow and distribution, thinking of a whole body experience. So this is very historical footage, and with John taking these first steps in 25 years and certainly becoming the first paraplegic to ever be wheelchair bound for that period of time and take those steps. Oops, sorry. Get this one there. So it's quite good. And we're keeping it lighthearted. And that's one of the things that we're coaching people all the time. Not to over focus on things, just keep it nice and light and just let the body do the processing. Could everybody hear the audio then? Can somebody let me know? Was the audio, could people hear the audio? Okay. So within 18 months later, John went on to complete a conventional triathlon. So see him coming across the line there with his son and his beautiful wife. So much to a big applause of many hundreds of people in the crowd there. Not anything less than that was Kylie. Kylie, all these people, these are well publicized, so they're all permission is given to use their name, etc. So Kylie was an elite athlete. She represented Australia in touch football, and they thought that she'd torn her hamstring, and they were treating it as such. They waited until it had a 2 litre blood supply before they saw it as suspicious, and that brought about the removal of her complete sciatic nerve. Her total hamstring was gone, of course, and 3/4 of the adductor pathway. So it was all considered that Kylie was never going to be able to bend her knee voluntarily, certainly squat down with that leg, walk without having assistance like braces and crutches and so on. That's exactly how she presented to us. Now, within 2 months of neurophysics therapy, again, going through the grids, and just like a stroke survivor, one hemisphere teaching the other hemisphere about what it needs to do in each point in space-time to be able to mirror the opposite side. So we see Kylie standing there, and she was performing all these movements. I'll show the video footage of that just to verify how she was able to do that. But having to ask questions like, okay, how did this occur? Did cells convert from antagonistic to agonistic to be able to vice versa under those conditions? So, and it's never about what a person is able to accomplish on one day, particular day. It's what their intent and focus is as they're trying to perform those movements. When they go home and they're rested, that's then their system will use that data or that information, if you wish, to work out what it needs to do to become more effective. And that's no different to any athlete with their skills training. They might not be able to perfect the skill one particular day. They go home and rest. Their brain goes through all the conformational dynamics and detrends the data to bring forward the outcomes, the efforts that are going to be much more beneficial, so that when they arrive the next day, to go back to their sport, everything seems to be improving. So there's nothing unique about that at all. So here's Kylie performing these operations. You see very stable through the adductor pathway. The hamstring's very much involved with that, of course. Let me slip over to these slides. I don't know how these films reverse themselves like this because it is her left leg. So you see nice and stable, and the focus is there, staying relaxed, staying composed, letting her body sort it out where minimal effort is required to be able to perform these movements. And of course, this one was doing bipedal activity there. Again, see a lot of stability through that adductor pathway and just working through that fixed plane. And that's all courtesy of the grids to bring about that level of stability. So this is Michelle. Now, obviously, if you can't hear the audio here, there's no point in keep on playing it. But just for now, this is FSHD, muscular dystrophy, so facioscapulohumeral dystrophy. Michelle presented, so she was 59 at the time of treatment, diagnosed with at 33. She was quite advanced. She came in as assisted standing and walking only. She came in with a walking frame, frozen and painful right elbow, low endurance, speech and facial expressions, which is affected, of course, with FSHD difficulties. This testimonial was done within 3 days of neurophysics, post the end of 3 days of neurophysics therapy. So I'll let Michelle tell the story here. Where's this little thing? I don't know what's. Yeah, so under those conditions there, when I was holding Michelle in certain locations there too, that was just so that her system could build up velocity at that point. I wasn't actually doing anything, just holding on to try to stabilize that point. So under those conditions, the system can reflect upon itself and start to look at what's normal, where the restraints are. And then it very quickly sets about trying to remove those restraints in order to assist itself with functional. So it's always treat the person and not the disorder, regardless of what it is. So people with spinal cord injuries, they were a person before they had this spinal cord injury. They're not defined by that at all. They've probably had underlying stresses and anxieties, which we find. So all of those things and all those false percepts of the environment, they all need to be taken care of so that when the person's having a thought about sending a signal through their body, there's a much cleaner line of communication, noise-free. So it's very, very important to allow that focus on, they're a person, a human being, pathologies and that emerge basically from perception. So it's always that case of treating the person, not the disorder. So, so I don't know why these videos show up as black, but this is targeting the sensitive, vulnerable regions of the system. So this particular, these exercises here. So again, this is working through the grid. So this is Anna, she's in her 3rd week of therapy. So a lot of the original anxieties that have been dealt with. But the pectoral region there, those fibers are very intimately connected to all the higher order fear and emotional regions of the brain. So you're perturbing that by going through this process. The gating of the legs is important. So if I was watching the legs and they start to move in towards one another, that would tell me that her system is going into protective state. Let's get that off. Going into protective state. So all the time she's doing that, she's picturing where her hands are relative to her feet, picturing herself inside that grid. So gravity, that vertical constant of gravity, is the main rule that her system's responding to there. As that plate is moving up that stack, the gravitational effect on that is increasing the stress of the environmental stressor into her system. When she gets to this point, this is when she can change the narrative by thinking about talking herself up, getting a heightened experience of herself under those conditions. She might have originally felt anxiety at that point, but she can convert that into something useful. So by altering the narrative. And because she's got her nervous system's attention under those conditions, neurons will fire towards one another, developing relationships with one another based around what she's thinking about, what the goals and objectives are in that case. And then they develop long-term relationships over time. So she develops a new stable reference points that overrides all the other previous reference points that were there. So up onto this one here, the adductor pathway. So this is again a highly sensitive area. So if something comes into that space, like the pectoral area, we're going to form a protective posture. We'll bring those legs together. So by going through here very slowly, again, you'll picture a lot of underlying anxieties and fears that might emerge through that state. And usually you see when they're first going through that there's a lot of iterations. It's not just moving through smoothly, it's jumping from point to point as they go through. So there's a redundancy in there, and that redundancy shows up at all scales of the sensory experience of our world. Redundancy would be in the visual system, in the auditory system. So creating false perceptions of the environment. So again, she's holding it there, talking herself up, getting that heightened sense of self, and moving back slowly. It's very important going back the other way to keep in contact. So the going back, we're showing no bias between stress of the environment increasing value and decreasing. Is keeping connected to it all the time. The human error comes from when we apply a stress to ourselves and then we relax, apply a stress to and relax. So people training in gyms, you often see that. And we don't experience life as a sudden stress, then emotional withdrawal. So we've got to keep connected all the time, making seamless transitions. So it's a nice seamless flow of information going through the body. So here we're on to this other exercise now. This one is to help maintain postural tone. Good postural tone, but the other objective is, of course, is trying to detrain the overaction of the trapeze muscles. So again, the stimulus is very light. All she's doing is moving through that space. When she's at the bottom of the movement there, she's able to experience that as a sense of dominance and authority, overriding any other pre-existing feelings that she might have had about that. When she's going back up, she's got to focus on not engaging the trapeze. And this is where it becomes counterintuitive, because under these conditions, and with this particular exercise, people can always usually demonstrate that they can take the stress on, they can reintroduce the stress to their bodies and not react in the trapeze. But when they go to let that go, that's when they tense up. So it shows that there's some aspect of a person's life where they're very good at taking stress on, but have great difficulty in letting that stress go. And that's the point of it becomes that allostatic overload. Now, we know it's compartmentalized like as such because when we get on to the next movement, which is the same, targeting the same area, where the person's bringing their arms in towards their body on a linear plane, they'll tense up coming in. They don't have any problem letting it go. So there's two distinct ways of dealing with stress dependent upon where it comes from. So the person has to learn to be able to dispose of all those discrepancies. So if I was in another room monitoring what was going on in their trapeze, I shouldn't know what machine they're on, whether they're gay, whether they're going through the concentric phase or the eccentric phase, because it should be seen as a continual flow of information. We've got data that very much verifies that accordingly. So noisy inputs infers noisy outputs. Let's see if I can get this top part up. Noisy outputs. So we've already discussed that. So a person going through, so we see in neurologically compromised patients that increases in anxiety amplifies symptoms effects. So this is pretty common in neuro. So the symptoms might gradually increase, their level of anxiety increases, as the level of anxiety increases, their symptoms increase. So it creates this positive feedback loop that keeps amplifying those experiences. So we've got to help the person to transcend all those previous experiences, learn to relax under these controlled conditions, apply the environmental stimulus to themselves, and then modulate that experience to put it into something that's useful. And like I said, things can change and emerge in pretty small timescales, provided the person wants to get well. So there's a lot of cognitive focus has got to take place. So hence the perception, action, and cognition. We're always perceiving the environment. We need to be acting upon the environment in some prescribed and meaningful manner, and then cognitively learning to identify sensory perceptual errors and correct those errors. So as I said in the early piece, I had to look at things through a new lens, so looking at complexity science and asking certain questions about why does a system from one state suddenly go into a history where there was a healthy system, now it's turned rogue and gone into another state. So emergence is part of what we see, so emergent phenomena. So it's rather than focusing on rehabilitation, we shouldn't even really use only RE words in biology because it always suggests the back transition. So we can only ever move forward. We can only take a system from its present state and enhance its qualities and functions. So you can't rewire the brain. Likewise, you can only just take the brain from its present state and enhance its qualities and functions. So emergence, human beings are extremely sensitive to initial conditions. So we need to learn about something, how the person's perceiving the environment and what those initial conditions are. So there's certain other tools that we can use, that anybody can use, to be able to see what some initial state of the person's system is and how they're perceiving it. And by simply working through the grids and keeping it all innocent, where there's no real agenda, just go through, clean everything up, get rid of, dispose of all the sensory perceptual areas that are giving rise to these things, you're altering those initial conditions. And it's like altering the algorithm that's giving rise to something. So we're going through, and then what the outcomes that they're looking for, that just becomes emergent phenomena. It just emerges from doing those things. This was the model that I developed all those years ago. It's not that categories very easy. We put it into the categories like this, but it's to demonstrate that posture is our number one rule. So everything in nature is being calibrated to that vertical constant of gravity, and that's something that we all must remember, and the reason posture is so important to us. So when we've got our ideal posture, when we're applying to that vertical constant, we have apparatus in our brain that helps us to calibrate to that vertical constant of gravity. But out in nature, there's structure, there's organization. We see gravity goes one way, the ocean goes horizontal to that. So we see that there's math involved in that, there's structure and organization. So we need to have some structure and organization, return to the system. But of course, when they're moving through the exercises, they've got to try to maintain posture. So if they start to compromise their posture, they're moving into a protective state. The regulation of our emotional experiences, and when we talk about emotions, it's referred to as energy in motion, or that which sets in motion. We think, we feel, we act, it's all energy in motion. The idea is having control and authority over that energy and motion. Environment, or meaning perception of the environment, plays a role in our posture, maintains emotionally, help us to maintain emotional integrity. As I said before, you're not going to see a depressed person walking through a shopping center, chest out, shoulders back. They'll maintain a certain postural state that maintains their metabolic conditions that give rise to the perception, to the depression. So our perception of the environment, the accuracy of our perception of the environment comes from posture. And with exercise, aging and eating playing a lesser role because there's so much variables in exercise. There's people with all sorts of exercise programs, and some people exercise a lot and don't really get much out, and other people don't even exercise much and they're healthy and well. But we can use the mechanics of exercise to restore favor in terms of posture, emotional integrity, and accuracy of the perception of the environment. Aging is an inconsistent because people age at all different rates as opposed to a group of animals together with all age at pretty much the same rate. And of course, eating is much more variable as well. And it's something that we can use the mechanics of eating, again, to help to stabilize the system. With food is just another source of information that comes in from the outside world that tells a story about our environment. Is it stable? Does it have the things that I need? So with food, we need to have lots of stability with what we eat, as opposed to getting told we need lots of variety. We don't. We need lots of stability. With exercise, we need lots of variability because our system will adapt very quickly to the exercise experience. So there's whole programs that are related to that. So all the people that come to us, conditions, every single person has been long-term posture compromised. And, we see the beautiful data that we've taken years ago with the ECG, EMG, and the EEG. We've seen that when a healthy person standing at that vertical constant, there's a nice flow of information going through. You can see literally what's taking place at all scales. It's all matching up. If you move that person away from that vertical constant, that's when you'll see noise build up. So again, that would be stimulation to the basal ganglia and the cerebellum, trying to normalize that person's system. And it's that long-term stimulation to areas like substantia nigra, where I would argue that once it reaches a certain threshold, that's when neurons are going to start to switch off and end up with some other types of symptoms, other types of tremor will emerge that relate to over-oiliness in the system. So proprioception, very important. Proprioception is just nested within our perceptual landscape as to what we perceive to be our reality. So if we see errors in proprioception, it's a given that there's going to be errors at all other levels of percept. Now, that was in the literature years ago, so there's nothing new about that at all, but it's something that just gets overlooked. So the simple act of a person sitting on the end of the bench, and you can do this experiment with anybody, sitting on the end of the bench with their eyes closed, moving their arms across their body, pointing their index fingers towards one another nice and slowly, not fast, slowly, and then you'll see all the different changes of behavior as they're coming through. But the idea is, of course, it's not about guessing and hoping that they touch one another. It's about knowing that they're there. Now, whatever you see in terms of some compromised response to that as they're coming through, that's interconnected to everything that's going on in that person's system, the good, the bad, the indifference. It's a relationship the person has with their environment across all scales. And the elegance and the simplicity of all this is that because that's interconnected, by the person practicing this and make sure they can maintain it where they can actually get that accurate 100% of the time, they've altered their state of their system. You have evidence that neurons in their brain body system now firing differently to how they were before. With a pre-existing condition to stay there, it would need those errors to have been maintained that they were initially making, because that was the relationship. Now they have a different relationship with the environment that's much more deterministic. One finger at a time, to the tip of the nose and back to that finger. And what you're looking for initially is the movement. This is where a lot of people suffer discrepancies in depth perception. And I blame the technology that we use for that, because we're looking at the depth that we have there, and we're seeing landscapes within our technology that aren't real in terms of the depth, so it interferes with depth perception. So like I said, all that has to be corrected because it is a very fundamental thing. So we've got to look at the fundamental things first, rather than looking at trying to do complex things to correct complex disorders. So as I just mentioned, that's just a bit of literature about what was in the scientific literature before, verifying that proprioception, errors in proprioception lead to other perceptual errors across all scales. The other thing we see, which is a very fundamental thing we do, is when we were children, we all sat on the end of benches and we flopped our legs back and forth. We didn't think about that at all. The brain generates those movements. It's spontaneous, because it's like as if the brain is constantly trying to keep things synchronized. Then as an adult, the person goes to do that and they start to perform those basic movement with their eyes closed, and they can see that it's all clunky and they're very iterated. Now, that means that they're trying to send a signal through their body to perform something that is very fundamental, very important. And their system, there's too much noise in their system, competing information going through. Again, that's relevant to everything that's going on in that person's system. Whatever the disease or disorderly state that's in, it's all relevant to that. It's all interconnected. Now, it's because that area there, that reductive pathway, It's a very, very complex region. Quadriceps and hamstrings are just for forward and back locomotion. That pathway there, that's got to manage our whole three-dimensional movements in space-time. So extremely complex representation up in the brain. Now, if there's all that discrepancies that are in there, as the person's walking around, because the information is coming up from their feet up to the brain, as they're walking around, there's complete randomness taking place there. It doesn't have any deterministic value whatsoever. And it keeps the body in a protective state. So their background tone will increase, which is what we feel when I try to butterfly their legs back and forth. You'll feel that increased in vigilance in the system. So they've got to practice that, trying to get those legs to be nice and floppy by holding one leg still and just trying to perform it with the other leg. We can see a hemisphere dominance. If the leg they're trying to hold still is difficulty in holding it still, we can see that there's a dominance factor there. And usually they'll find that there's some difference between what one leg can do to what the other leg can do. So they've got to keep practicing that until they get rid of that and develop a sense of sameness. So that's where the cognitive awareness has got to come in. So one leg feels the same. Because as I said, if they're walking around and that sameness isn't there, then every time they put their left foot on the ground, that's telling a different story to the brain to when they put their right foot down on the ground. And that has an effect in terms of the system trying to maintain a more protective state. Standing on one leg at a time with eyes open initially, some people can find that difficult, but that is a joint venture between the two hemispheres. The ability to hold one leg up while the other leg is being supportive, that involves the whole brain, of course. So that's what's got to be practiced. And then, of course, when they close their eyes, that's when we can verify how rogue the visual system is, because it's like then they sort of start to move all over the place. They have no idea. Now, there shouldn't be a lot of difference between eyes open and eyes closed. So they've got to keep practicing those type of movements until that sorts itself out. But these are big game changers. They're making very big wholesale changes to the person's initial conditions that are interconnected to what the condition was when they presented. But like I said, anybody can do this. People should practice these type of things themselves to be able to tune in and dial in on themselves a little bit better. So those things have to be corrected. So as I said, it's just using the mechanics of exercise to gain a control over the health and wellness of the future of the system to become more robust and impervious to world noise. So going through the grids provide that nice stable backdrop to be able to measure point-to-point operations in space-time. We can hold it at any point. We'd see all this in the data as we're taking through, and you can see the alterations of behavior emerge in very, very small timescales that give rise to the improvements the person's making. We've had some publications in the World Journal of Neuroscience that relate to genetic disorders like FSHD and hereditary spastic paraplegia, where people have presented to us with advanced stages of those conditions. And the same thing within 4-day period of time, they're very much doing lots of things. So I had to ask the question, the role beliefs play in perception and the likes playing, especially when things like hereditary spastic paraplegia, where the study we did involved father and son who'd been long-term and were advanced. The grandfather had it, the uncle had it. So were they conditioned as young men, to believe that they were going to get the condition? Because the genes that were supposed to be responsible for that, what happened to the genes in 4 days that all of a sudden these returns of lost functions were there? Same with the FSHD. So, like I said, asked other questions. I have a publication now that's just been accepted in the Journal of Behavioral and Brain Sciences, where I brought beliefs and perceptions onto the table. That was a very, very difficult publication to get accepted. I spent months and months battling with reviewers about that. And I was asking the question, I had to ask the question to the reviewers, if they're not comfortable with the way I was describing it, to provide me an alternative view on how that was possible for these advanced stages of FSHD and muscular dystrophy, to be able to do that. So after a little bit of further battling, it was accepted. So I'd like to thank you all very much for persevering with my presentation today. As I said, it's always an honor to present at these conferences, and it gives me a great feeling. I'm pretty much alone out here in Australia with my work. It gives me a great feeling of camaraderie. So I thank you all very much for watching my presentation.